Good morning, everyone. Welcome to the Men's Health 2020 event for Hamilton Medical Center, and hope everyone is doing well and safe. We typically do this in person, and unfortunately, with the events we have going on, we have to do this virtually. So we've made a few changes and put a little bit of new information like we try to do every year, but we're going to, it'll be a little different. We're going to have a little quiz during the presentation about prostate cancer, and feel free to answer those questions, and I'll try to go over them. And then at the end, I think we're going to have everyone hold their questions, or you can send them in as we go along, and we'll try to answer as many as we can. So without further ado, we'll get started. I will be the MC for this event. Unfortunately, Dr. Vase is not going to be with us this morning, nor is Dr. Rojas. So we'll go over, I try to do basic education about urology and some urologic issues, but primarily we'll be talking about prostate issues, some issues about erectile dysfunction, low testosterone issues. So I often get asked, what is urology? And many times urology gets confused with neurology. But urology is primarily a surgical subspecialty for men and women, where there is lots of pediatric urology. However, our practice focuses primarily on adult, male, and female urinary tract issues. And kidney stones, urinary tract infections, prostate issues, cancers, incontinence, erectile dysfunction, those are kind of our primary disease processes we take care of. Today we're going to, as I told you, it's a men's health event, so we're going to focus in on the men's issues. So September is every disease process has to have a month, and September is a good one, and it's Prostate Awareness Month. So I also show every year, we try to show a picture to get you an idea about the lay of the land, or our processes we take care of primarily in the pelvis. And you see this picture here. This is the bladder, but it appears to be fairly hypertrophied. Actually, the bladder is a very thin muscular organ. It's a smart storage unit. This is the prostate here, and you void through the prostate. The bladder contracts, the sphincter outside the prostate relaxes, and you void. But it's a very low pressure system. The ejaculatory ducts go through the prostate, and obviously the urethra is here. Lymph nodes, and we'll talk a little bit about lymph nodes, but when we look at our pelvic cancers, especially prostate cancer, lymph nodes are adjacent to the prostate. Okay, so the prostate is primarily a reproductive organ. It surrounds the urethra. You void through the prostate. Prostate enlargement issues are just very common. In fact, almost all men as they age will have some prostate enlargement. Most of these issues are not related to malignancies. And just the fact that you have an enlarged prostate doesn't typically increase your risk for a prostate cancer. As I said, as you age, you're going to have more of a likelihood to have some issues with this benign prostatic hypertrophy, or BPH. And it's a linear relationship with age. So as you age, you're more likely to develop a problem with prostate enlargement. So if you're in your 80s, you're looking at 80-90% chance you're going to have an issue with BPH, or at least have BPH. However, some men will have these issues in their 20s and 30s. We see lots of men with prostate infections and inflammation that ultimately lead to some prostate problems as they age, or more prostate problems as they age. Even though most men are going to have prostate enlargement, only about half of the men will have symptoms, and these symptoms are fairly germane. In fact, you come to our office or look at any website, they're going to have a list of these symptoms: the terminal dribbling, the inability to empty your bladder. Incomplete bladder emptying is a term for that. Incontinence, which we see in both men and women. This urinating at night or nocturia, slowed urinary stream, and these last two here, painful urination or blood in the urine. I mean, we can see that with benign disease, but also if if you're having those issues, you could have something more serious going on, like a malignancy. But this constellation of symptoms we kind of refer to as lower urinary tract symptoms. And this is what leads people to come to our office, particularly these incontinence issues, the terminal dribbling, or blood in the urine. So the way we treat this is, many times we'll do some lifestyle changes. It could be as simple as just modifying medications, or when you take your medications before you go to bed, your fluid intake, what you're eating before you go to bed, just using the restroom before you go to bed at night can limit some of these nocturia issues. So we'll find that those things can modify your urination issues or those lower urinary tract symptoms significantly. However, we still have lots of medications. There are actually two classes of medications that are commonly used: the alpha blockers, and then there's a class of medicines that actually shrinks the prostate a little bit. These alpha blockers, most people are familiar with them. It's Flomax, or the generic form of Flomax is tamsulosin. These medications actually block the neurotransmitters when you initiate a void, and make it a little easier for your bladder to empty, effectively opening the bladder neck a little bit, relaxing the prostatic urethra. They don't actually shrink the prostate. The two medicines, finasteride and dutasteride, do shrink the prostate a little bit. We used to think it shrunk the gland significantly, but studies have been done which show that probably only shrinks the gland about 15 or 20%, 10% or so, but that's enough to help your voiding. We also know that all medications have side effects, and we'll talk about that as we go along. Some of these medicines affect your sexual function, and can be a lasting problem. The herbal agents such as saw palmetto, there's actually good data on that. They help. They don't work as well as the prescription medications, but they do have some effect on your voiding. We see some synergy with our medications and our herbal agents, so we use them together for a better result. The problem with the over-the-counter things is there's very little oversight. So FDA does not regulate those at all. There's billions of dollars spent on herbal agents, and some of them just don't do what they say. So you have to be very careful when you're picking something at the pharmacy, or you watch that commercial. They may have the slick advertising, but the efficacy may not be there. We also do lots of office-based procedures or have done these for a number of years for prostate enlargement, which are quite effective. And as technology gets better, those therapies get better and better. Everyone's familiar with the old Roto-Rooter. That's changed dramatically with technology. All the surgeries for prostate cancer are done using lasers or ablation techniques. They're typically outpatient. They don't require catheterization as much as they used to. So patients get over these procedures much more quickly and are back to their baseline or an improvement more quickly than it used to be. So now we're going to talk about prostate cancer. these numbers fluctuate. I try to update them, but technology and advancements in medicine have really made an impact on our treatment of prostate cancer. It still is the most common malignancy for men over 50. Um, and that number fluctuates somewhere between 180 and 210,000 cases. The incidence of prostate cancer is roughly 1 in 6 or 1 in 7. Cancer deaths, somewhere in the neighborhood of 18 to 21,000 year in and year out. There are in the United States over 2 million men living with prostate cancer, either on surveillance or who have been treated. And as any malignancy, most of them, early detection leads to a better result. So, screening, and we're going to talk some more about screening. However, if we start out with a very aggressive cancer, where we start with a malignancy depends on where you end up. So aggressive malignancies are harder to treat. However, prostate cancer is one of those where a lot of the cases are low grade, low stage malignancies. So screening for prostate cancer, we screen for a malignancy when we have a common problem that we can actually make an impact. If early detection will make an impact. I just mentioned that some of the malignancies we can't really make an impact on, or they're not very common. They're not. We don't see enough of those cases to actually screen. But prostate cancer, breast cancer, colon cancer, we screen for those malignancies because there's so many cases, and we know that early detection will make a big difference. It also changes the treatment options. There are a number of societies that have treatment or that have screening guidelines. I've just listed the American Cancer Society guidelines. There's NIH, there's NCCN, there's AUA, there's, you name it. There are a number of societies that have screening guidelines. But one of the things that we've added to our prostate cancer screening guidelines a few years ago is that we definitely want men to know that they're making an informed decision with their doctor or provider once they begin screening. The evaluation has some impact on people's lifestyles and actually carries a little bit of risk. But typically, men start screening when they turn 50. That is, if you have no risk factors. And the risk factors are primarily a family member with prostate cancer, and that's typically a first-degree family member, such as a father or a brother. And we can look at second-degree family members, such as uncles and cousins, and that does have some impact, but the first-degree family members are the most important. So if you have a brother, you have a father that had prostate cancer, particularly if they were diagnosed at an early age, before 60, that's a big risk factor. Also, African American men are at higher risk for a number of reasons, and it's really beyond the scope of this discussion. But those are in the United States, those are our two groups that we look at as high risk patients. But those patients with high risk or who are at high risk, we need to begin that screening at least by age 45. And if you're a significantly more higher risk, as I mentioned down here, multiple family members, early age of diagnosis, you probably need to start that around 40. That is this, and we're going to talk about that in just a minute, the PSA and the digital rectal exam. So everybody wants to know about PSA. What is PSA? Well, it's specific to the prostate, hence the name, prostate specific antigen, PSA. That means it doesn't come from anywhere else. We don't get it from your thyroid gland. It doesn't come from your liver, your colon. It only comes from the prostate. It is a hormone-like substance that's produced by the prostate. It contributes to the health of the sperm. Used alone, it's probably not a very good screening test. We used to, before the discovery of PSA, we used something called acid phosphatase to follow people or diagnose or help diagnose people with prostate cancer, and that was a terrible screening tool. It was actually good for following patients with advanced prostate cancer, but not good for screening. So the advent of PSA made a huge difference in the screening and the detection of prostate cancer. But it has to be coupled with a digital rectal exam, the finger check, and put in context with the patient's history. That's very important. So I always have a picture like this in so I don't forget to talk about digital rectal exam. Some of the societies and guidelines don't recommend digital rectal exam as much anymore, but we still recommend that. Urologists and people that take care of patients with prostate cancer, we recommend that you have a yearly digital rectal exam along with your yearly PSA. So people ask me, are there symptoms? What are the symptoms for prostate cancer? Well, it's fairly insidious. It's a silent process most of the time. You can have symptoms. I mean, there can be BPH-like symptoms, but typically patients do not have a lot of symptoms for prostate cancer. In fact, we want the patients we're diagnosing, it's much better for you if you have very few symptoms. Patients that are symptomatic, more times than not, are symptomatic from prostate cancer tend to have more aggressive disease. But again, the detection is that PSA blood test starting out with the digital rectal exam. Now, technology has been great for our screening for prostate cancer treatments for prostate cancer. So genomic testing or genetic tests are very important. In fact, it's within all our guidelines for at some point for patients to look at some genomic testing or at least consider it. But there's a number of them that I list here. Some of them are urine tests, some of them are blood tests. But basically what they're doing is we want to try to risk stratify our patients. So we want to put people in categories so we can treat them better. We want to identify those low risk people. Well, if you're a low risk person for prostate cancer, we probably are not going to follow you as closely. But if you're higher risk, we want to follow you very, very closely or evaluate you further to try to diagnose the disease. So you'll see a lot of this. There are a lot of these tests out there. These are just some of the ones we use. And like I said, there's some of our colleagues still don't believe that there's enough literature on this, but we've been using these tests for a number of years, and we find it very effective for helping treat our patients. So the treatments for prostate cancer. The first one we always talk about, and we've been doing observation for prostate cancer for years. We were even doing it before we had good literature to support it, but we have overwhelming literature that shows that for a majority of patients with low-grade, low-stage prostate cancer, that you can do surveillance, at least for a period of time. And, this surveillance, we've now changed it to be called active surveillance. But it's basically observation. And what you're doing is we're checking blood tests, doing the digital rectal exam, taking a good history. And we also implement repeat prostate biopsy and MRI. And MRI has become more and more important for patients in the diagnosis of patients and also the treatment or how we follow patients on surveillance. And so all our guidelines recommend that at some point you have an MRI. And I'm very happy to say that at Hamilton Medical Center, we're upgrading are soon to be upgrading our MRI technology, and we'll have a new 3 Tesla or a 3T or a 3 Tesla magnet here. We're very excited about that. That really helps our patients here in North Georgia, and we can't wait for it to be fully operational at the medical center. So surveillance, observation, typically for patients with low-grade, low-stage disease, we know that studies show that even if you're on surveillance and you progress, those patients do just as well as if we'd have treated you initially. So let me try to make that clear. So if you had intermediate or low-grade disease and we put you on active surveillance and you progress, treating you at that point, your outcome is the same as that if you did it initially. Okay, and you have to think about that for a minute, but that validates surveillance, especially for patients with advanced age, multiple comorbidities or medical problems, and low stage, low grade disease. Although we find that some of the patients that have intermediate grade disease, it's safe to do surveillance. Radiation therapy is one of the two treatments that we know that is superior for patients with localized prostate cancer. External beam radiation, or the newer type of IMRT radiation, is IMRT is the gold standard for radiation therapy for localized prostate cancer. We have a great setup for that here at Hamilton. Treat lots of patients with that. We've had some advances in what we do for patients prior to receiving radiation, such as using, we place a hydrogel that actually lifts the prostate off the rectum, which makes radiation much safer for patients. And just the technology, the computers, the things that we have that allow us to very precisely deliver radiation therapy for patients in the pelvis have made that much safer. Brachytherapy is the seed implants that most people have heard about brachytherapy. Brachytherapy for low grade or low dose brachytherapy seed implants are not done as much anymore, primarily because most of the patients that have low grade, low stage disease do surveillance, or we recommend surveillance. We still use brachytherapy, and it's a very effective treatment. It can be used in combination with external beam radiation. We also, for more advanced patients with more advanced prostate cancer, we can do this technique called a HDR technique, or a high dose radiotherapy technique, which we're doing here at Hamilton Medical Center with our radiation oncology colleagues, and it's very effective. Ablation therapies such as cryosurgery or this HIFU, this ultrasound therapy, these are FDA approved treatments. We've done a lot of cryosurgery here at the medical center over the years. Again, it's another one of those techniques that at this point, with most of our patients with low grade disease being on surveillance, we don't do quite as much of it as we once did, but it's still safe and effective. And I think you will see a resurgence of these techniques as technology catches up, because we're looking at doing more focal therapies. It's almost like doing treating the lesion within the gland, so to speak. And as our imaging and MRI and ultrasound technology improves, we're able to deliver those treatments very, very precisely and very effectively. But the gold standard for treatment, or the primary treatment patients are having done for low grade or for localized prostate cancer in this country, is radical prostatectomy. And the gold standard for radical prostatectomy is robotic prostatectomy. You'll see this term radical prostatectomy. It's not a political view or some kind of aggressive surgery. It just means that we're removing some of the tissues around the organ, potentially lymph nodes. It's a more complete cancer surgery rather than some type of simple surgery that we would do where we're not worried about cancer. So there's either staging or treatment implications when a radical procedure is done, when we remove a little bit more tissue, meaning we know better about how that disease is going to behave for staging, or we see treatment or therapy or a better treatment if we remove more tissue. But the robotics is just, it's an amazing platform, and we're so thankful to have the new Da Vinci Xi robot here at Hamilton Medical Center. It's just a wonderful system to use. It makes the recovery for patients so much quicker. The surgeries and the dissections can be so precise. So this picture right here just basically shows again the prostate and the bladder. It gives you an idea of what we do when we're doing surgery. We're actually disconnecting the prostate from the bladder and disconnecting it from the urethra, and we disconnect these blood vessels, these things that kind of look like blue train tracks underneath the structures here are the neurovascular bundles, and those are the structures we try to save that help with your continence some and your erections after a prostatectomy. So we can do these very precise dissections with robotics now that we couldn't do before. Then we're able to use the robotic arms to do a very intricate anastomosis where we sew these two structures together, the urethra, which is a tube, and we connect it to the bladder. This is just a picture from one of our cases. I think I've had it in here for a couple of years, but it gives you an idea of kind of looking down into the pelvis. To orient you, this is the colon, the bladder's here. I haven't taken all this down. The prostate is deeper and beyond this. So if you think about these prostatectomies, it's kind of like take a small trash can or a small tube and then try to get your hands down in there to work. So it's very difficult. The robotic arms make pelvic surgery so much easier. We can, like I said, you see these instruments. I have a number of different instruments that I can use, scissors and graspers and staplers and things to take vessels. And I mean, it's just an amazing platform, and it's one of the greatest advancements it's the greatest advancement that I've seen in my career for surgery. So patients have localized cancer and are treated, but then they recur and have advanced cancer. And it's a very sad thing, but that's something that happens. We've had an advanced or prostate cancer treatment clinic at our practice for over a decade now. And we give patients hormone blockades for advanced prostate cancer and other malignancies. One of the exciting things we've been doing for about 8 years is we do some immunotherapy that we can deliver. It's a T-cell therapy. Some of you may have heard of it. It's called Provenge. It's a targeted T-cell therapy that we can do, and it's very safe for patients with advanced prostate cancer. There are bone targeted or bone directed therapies that we can do, radiopharmaceuticals, clinical trials that we're able to put patients in. And with the People's Cancer Center, we're able to do that so much more effectively now. Our medical oncology and radiation oncologies that work here at Hamilton we're able to deliver a team approach and take care of not only our patients with localized malignancies, but these advanced malignancies such as prostate cancer. And every year we have dozens and dozens and dozens of patients that progress with prostate cancer. It's very unfortunate. I get asked, Doc, I've been diagnosed with prostate cancer. What's my risk? What you do these treatments, what's my risk of it coming back? Well, the truth is it comes back to what I initially said about, if you have low-grade, low-stage disease, you're going to do much better. If you have aggressive or advanced disease, guess what? You don't do as well. However, these treatments, and they're changing all the time. We have these wonderful anti-androgens. You'll see these commercials about lung cancer for immunotherapy. There are a number of different treatments that allow us to treat very advanced cancers, and prostate cancer is one of those, very effectively and lead to months and years of productive life for patients with these advanced problems. A little bit about prostate cancer prevention. Healthier patients get fewer cancers. They do better with treatment. Their outcomes are better typically. And that always starts with exercise, a healthy diet, and a healthy weight. Okay, and prostate cancer is one of those. You can look at colon cancer, but the data is fairly robust with this, and we encourage our patients to clean up their lifestyles, when they're diagnosed with any malignancy, especially prostate cancer. All right, so let's talk about, we're going to change gears, erectile dysfunction. This is our most difficult discussion we have with men. This is always we've talked about some other issues, and I'm about to walk out the door and they're like, oh, by the way, I'm having some problems with my erections. When literally it was the reason you were there to begin with. It's not necessarily a normal process of aging, but it can affect men at any age. We see quite a few men in their 20s and 30s with these issues. And it's the reasons are multifactorial. Um, but ED at an early age can be a sign of serious heart disease, peripheral vascular disease, diabetes, and a number of other conditions. So, we know that, if we're seeing, even if you're not in your 30s or 40s or 20s, and you have acute onset erectile dysfunction, you probably need to be checked out, especially for heart disease and diabetes. So you can look on any website and see the causes, some of the causes for erectile dysfunction. Let's just talk about a few. These three in the middle. Tobacco is the number one. North Georgia and these Western Carolinas, East Tennessee, highest smoking incidence in the country. We always try to talk to patients about, putting down their tobacco products. Drug use, illicit or prescription drugs, that's hurting your erections. Too much alcohol, alcohol in moderation, and there's some guidelines on that, is okay. But daily alcohol consumption, significant alcohol consumption is hurting your overall health and hurting your erections. Sleep disorders, stress and anxiety, depression, all these things are serious health problems, and they're also serious problems for your erections. Obesity, we always have patients try to lose some weight. We want them to clean up their lifestyles. We want their chronic medical conditions such as diabetes and hypertension to be under good control. One of the things you'll see more, you're going to see these, now that we're playing sports again, you'll hear more about Peyronie's disease. And I'm amazed by how far the marketing people push the envelope on their advertising. Everybody's seen the commercials about the bananas and stuff like that. I mean, it's just makes me laugh. But yeah, we do have some very, Peyronie's disease is a real problem. It's much more prevalent than what we once thought. That's the curvature of your penis with an erection. These patients have more problems with erection issues, and we do surgeries, and we have fairly invasive procedures we do to treat these. But we also have some in-office treatments for Peyronie's disease that's very effective. So it's one of these things. It's kind of like erectile dysfunction was 25 years ago before the advent of Viagra. Nobody talked about it, and I was training and getting out of my training, and suddenly everybody's coming in and talking about this little blue pill, and it really has increased public awareness, and it's just a whole new area of medicine that we have now, basically because we have treatments for it. We're going to talk a little bit, low testosterone is also something that contributes to erection issues. And, I tell people, testosterone is not like jet fuel. It's like brake fluid or oil. You need enough of it. You don't need too much of it. You'd rather be, half a quart above on your oil than 2 quarts low. So this comes up quite a bit too, about patients saying, okay, I started a new blood pressure pill and it's messing up my erection, so I'm going to stop it. Well, that's dangerous. I mean, you definitely need to consult with your physician, your provider that's seeing you before you alter your medications. But again, many times if you can just make some lifestyle changes, you'll come off of some of those medicines and your erections will get better. So treatment options, we're talking a little bit about these lifestyle changes. That's the first thing we go to. In fact, we know that a third of the patients with ED are going to improve if they just make some of these changes. And it's kind of like one thing won't do it. Like if you start exercising, that's not going to be enough. But we know that if you exercise, you lose weight, you stop smoking, you sleep better, there's a cumulative effect that you will improve your overall sexual health, or you can do that. You have the ability to do that yourself. And a lot of that's common sense. Now, of course, we have the medications. I just mentioned Viagra. We have a number of other medications. One of the biggest things I'll say about the medications is, there is no panacea. The medications typically will help between maybe half the men to 2/3 of the men. That leaves a lot of people who are not treated by the medications. Um, a lot of the medications are generics. Okay, that's a very good thing. It's lowered the cost. You have lots of choices. You need to be careful on how you pick your generics. Quality of a generic is something you need to look at. Safety, we have, usually the safety of the generic is not in question. Many times it could be the quality. So you have to be careful. But we also do other therapies such as injection therapy. We use vasoactive agents, Bimix or Trimix. There's some expensive prescription name brand medications that can be used where you actually give yourself an injection in the penis, you get an erection, and it wears off. Probably the best way to go with that now is do something that's compounded. The pharmacies and the places that do compounding pharmacy are fairly well regulated, and all that stuff is pretty safe. So we are big advocates of injection therapy for the right patient. We also use vacuum erection devices, which are quite effective. There's good literature on that. And we can use these in combination with a medication or with an injection. We don't use injections and medicines together because you can get a very serious problem called priapism where you get an erection that won't go down. That's why when they're talking about the disclaimer that they have for Viagra and Cialis and all those medicines was, if you have an erection lasting longer than 4 hours, seek medical help. Well, may sound fun, but trust me, it's not. It's a serious medical emergency. So I just mentioned the combination therapies. And patients that have, I'm going to talk more about low testosterone, but getting your testosterone to a normal level is important. And then surgical therapies. We do implants and different procedures for erection issues that, those are some of our happiest patients. It's for a very specific patient. It's someone who has failed all the other treatments, and that's kind of your last hope, so to speak. And the implants are very effective, and like I said, they're quite safe. So low testosterone, we'll just spend a few minutes talking about this. It is a normal process of aging. We know that testosterone is dropping in most men somewhere between some 0.1% to 1% a year, and it could start very early in your life. Most of the time, men with low testosterone are going to seek treatment if they have symptoms such as fatigue or erection issues. But there's always a lot going on with these patients. Many times it's never more than just, okay, we're just going to give you a little testosterone and you get better. It requires more than that. And that's why we've talked about lifestyle, getting your medications, delivered appropriately or taking them appropriately. So there are many things that go into these treatments. And like I said, these things, sexual function issues, sleep disorders, just, people being kind of on an emotional roller coaster. These are all the things that bring people in for low T. But lifestyle changes help a lot, and we encourage that for every patient, just like we do for erection issues. The replacement therapies, we have gels and creams that are quite effective for the right patients. Injection therapy is probably the most common thing we do for low testosterone. That's where you actually inject yourself intramuscularly with testosterone. And this can be done weekly, every 10 days, every 2 weeks. We even have patients on monthly injections. If it's monitored properly, it's quite safe. And it's been done for a number of years. I mean, we have been doing low testosterone replacement for a number of years. And you'll notice about 8 years ago, you started seeing more advertising, more commercials on treatments for low T. Well, some things changed the way Medicare and insurance, pays for things, and suddenly the companies they innovate, and we have new medications. And so a lot of these things are very effective. Now, I've mentioned on here implants. We used to do quite a few testosterone implants. They're very effective and quite safe as well. There's even some oral therapies. We primarily do that for younger patients who are still trying to conceive children. One of the things that will happen for men is once you begin exogenous or testosterone from outside the body, your testicles is where the testosterone comes from. It actually quits producing testosterone. So, and it's a very, that's kind of a long discussion. I always have that discussion with patients when they come in. I also warn patients on these T clinics and some of these clinics that are around that kind of just take your money and start giving you testosterone. And we safety and oversight are good things, and so we encourage you to see your provider or your regular doctor or a board certified urologist, someone with some training for these treatments. But for the most part, if it's delivered properly and monitored properly, it's safe for a lot of patients. Oh, I'm going the wrong way. So,
I have a question if you want to answer a question about that. What about supplements that are advertised, especially in social media, specifically Nugenics for ED?
Yeah, so again, those over-the-counter things are marketing. Okay, so whoever pays for the slickest marketing gets the most business. So when you go to the pharmacy, you look at all those supplements. Which one do you pick? You usually look who's got the coolest label and which one costs the most. And if there's four and there's a cost discrepancy, you might pick the one in the middle because you're thinking the cheapest one can't be good. Okay, well, maybe that's true and maybe it's not. I know very little about Nugenics, but I will tell you that there are innumerable supplements like that. There is no FDA regulation of any of those supplements, and there is precious little oversight. So you have to be careful. I don't want to get too fancy, but everybody's heard the term caveat emptor. Okay, let the buyer beware. So you have to be very careful. There are some that are good, and there is some literature out there that supports, improved sexual function with some of these things, but they're expensive. I mean, when I'm counseling patients, I tell them to look at the cost and look what it's doing for you. And I see patients that are taking dozens of supplements. Why take so many supplements? I mean, they're probably not helping you that much, but there is a little bit of data to your question, and I'll get off my soapbox here. To your point and to your question, these things do have a little bit of efficacy. They are fairly costly, and you have to do your homework, so to speak. You usually, within a urologist office, you will almost never see a sexual health supplement. Why is that? Because there's just not enough data to really support it. You're going to see stuff about, urinary health. You're going to see stuff about prostate health. You're going to see stuff about healthy life. You're going to see a lot of things, but you typically will not see that. So I'll stop there, and I hope that answered your question. So one of the big things, I just want to end up with this. I'm almost done. I meant to tell you guys I had about 120 slides and we were going to go through them. So we're going to be here 2 or 3 hours. Just kidding. But these are some take-home points. It's recommended that 30 minutes of moderate physical activity for men. That is so important. 3 hours per week, and it doesn't have to be like you're out, lifting weights and doing crunches. I mean, you can walk briskly, you can do yard work, swim, anything you can think of. I've listed a few things here, but that's so important for your overall health. I think we've driven this home a lot. eat healthy, healthy weight, exercise, a good night's sleep. 7 hours of sleep is what's recommended. And I try to do that myself. I mean, it's so important for young people, but it's also important for men as they age. Alcohol in moderation, and there are just no redeeming benefits to tobacco. Okay. So thank you very much. We're going to take some questions. I want to tell Rachel and Jake, thank you so much. And Hamilton Medical Center, we try to do this every year, and hopefully we're getting a little better, and we can add some things to this. We can do it more than once a year, but there's some good things about being virtual here. We're going to go back to the way we did it before at some point, but I like doing it virtual as well, because I think we can reach more people. So thank you very much, and we'll try to answer a few questions if we can.
I think we just had the one question that came through, which you answered live already. The next line.
So I won't belabor this point, but we all are aware of the situation we're in. But wear a mask. I even asked him, should I wear a mask while I'm doing this? I wear my mask a lot. It's very important. Hand washing, social distancing. If people aren't making this stuff up, get a flu shot. This slide right here is probably the most important thing this year. These 4 points. Any other questions? I hope you have a wonderful weekend and a great 2020.